Oh, Jesus. Hello, John.
Hey, how you doing, Ulrich?
Hey.
It's Dylan.
Hello, Dylan.
Hello, Sydney.
Greetings, Dylan. You got in there, okay?
Yeah, John.
Good.
It's been a while.
With you in a second.
Something we need to do.
Having trouble getting Zolo. I'll be with you in a second, okay? Yeah, okay, Zolo, get in there. You doing okay, Dylan?
So, I'm doing great, John.
Okay.
Doing great. A little bit occupied, but it's okay.
Well, you know, turn off your video when you're presenting. You know how to do that, right?
Yeah.
Yeah. Okay. You probably know him better than me. There's Zolo. Zolo,
Hello, Dr. John. Hello.
you look like the ruler of Cameroon in your throne. I guess he couldn't hear my remark.
Yeah, I'm saying that the ruler of Cameroon is Paul Biya.
Hey, we have Ipe is here. You know Ipe, right?
Yeah.
Hello, Professor Ibe. Nice to have you. Yes, we all know Professor Ibe.
Okay, he's coming in now.
What an honor.
Yeah.
Yeah.
Hey, Ipe, can you hear me?
I can. Can you see me?
Yeah, I can't see you. I can hear you, though.
You cannot hear me?
I can hear you. Yeah, can you hear me?
Yeah, I can hear you.
Yeah, I can hear you well. You might want to work on your video there. Oh, there you go, Ipe. You're in, where are you at home?
Yeah, I'm at home.
Okay, there's a bunch of people here. You'll meet them all. Let me just do some, I gotta post it somewhere. I'll be with you in a second, okay? Okay, Dylan?
Yeah.
I'll be with you in a second. Okay. So I
Yes.
yeah, what do you want? This is great. You came. These kids are excited to see you. And you'll meet them all. But how do you want to do it? You want me to introduce you and then you can talk a little bit about it, or you want Dylan to go into his presentation and then you can comment?
Yeah, I mean, he can do his presentations and I'll
Okay.
comment.
Okay.
I'll be around and then I can comment as
Okay.
to, is he going to talk about herniation?
Yes, cerebral herniation. That topic I don't know much about.
Okay. So maybe he can go ahead with his presentation and then maybe I can tell him a few things. I can tell all the people about our concepts of herniation and how GCS changes with respects to each of these herniations, and what are the stages, and radiologically how do you differentiate these, and when is it important? You know, decompressive hemicraniectomy is a surgery that we wait till the very end. It's a very reactive surgery, while what we do, cystonostomy, is a proactive surgery. So it's very, very important for us to recognize the stages of herniation.
I save it for when we're recording. Hold on. Okay, let me start now. You ready, Dylan?
Okay, John.
Yeah. Okay.
I'm ready.
Yeah. Hold on. Let me 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, from Neurosurgical TV. We have the honor today of having the Association of Future African Neurosurgeons. We have Dylan Giofak. He's going to present on cerebral herniation syndromes. And we have graced with the presence of Ipe Cherian, well-known educator from Nepal. Hello, Ipe.
Hi there, guys. Good to see you all.
It's a pleasure to have you, Ipe. Elric at Harvard, could you please, I think you know Ipe, right? Ipe?
Oh yeah,
Right,
absolutely, absolutely, John. Thanks. It's such a pleasure to have Professor Ipe here, and I think the subject will be a good opportunity to see what he's done so far, this far with cystinostomy. We've had the opportunity to listen to some of his presentations on how he is able to unfold the brain. So that would be great to hear about that and what cystinostomy brings to traumatic brain injuries. So I'm Ulrich Sidney. I'm a research associate at Harvard. I'm originally from Cameroon, and I'm the creator of this platform, the Association of Future African Neurosurgeons. And I actually created this with a few people, among whom Dylan Giofak was going to be presenting today. So happy to have all of you here.
Yeah, Ulrich's done a great job putting this channel together based in Cameroon. Hello, Zolo.
Hello, Dr. John. Hello, everyone. Welcome, Professor I. It's an honor having you around. And it's a pleasure being here. I'm a neurosurgeon. It's an honor being here.
Welcome, Zolo. And let's see who else here. Marco, can you hear me? Marco just came in. Go ahead, Marco.
Hi, fellow. How are you?
Good. I'm glad you could come. Could you please introduce yourself?
Of course. I am Marco Meloni. I'm a consultant neurosurgeon in close to Como, North Italy.
Okay, welcome, Marco. Whale, are you there? Can you hear me okay? I'll unmute you. Go ahead. Whale, can you hear me okay? Possibly not. Chinmay, are you there? Chinmay, Balki? Maybe not. 2 in a row. Adnan, you're back. Adnan, how you doing?
Yeah, I'm fine. How are you?
Good. Could you please introduce yourself?
Yeah, my name is Dr. Adnan. I am a neurosurgery resident from Pakistan.
From Pakistan, your camera's not on, and we'll get to see you later.
Sorry.
That's okay.
Yeah, I'll try.
That's okay. We'll get it later. Okay, Dylan. Where'd he go? Where'd Dylan go? Okay, there you go. Okay, Dylan, it's all yours. And welcome. Go ahead, Dylan. It's all yours.
Okay. Thanks, John. Hello, everyone. I'm Dylan Giofak, general practitioner from Cameroon and member of the Association of Future African Neurosurgeons. It's an honor to have you all, especially Professor Ipe. It's really an honor. So today we'll be talking about the cerebral herniation syndromes. So I'm going to share my screen.
Dylan, while you do that, please, can you cut your video feed because the connection is not great?
Okay.
Thanks.
You okay, Dylan?
Yeah, I'm searching for the document.
Oh, okay, no problem.
Let me do this quickly.
We can always edit this out.
Yeah, I just need to.
While Dylan finds his presentation, I think there are a few people that just joined. I've seen Darwin Shishimba. Hello, Darwin.
Daywin, are you there? Let me unmute you there. Daywin, are you there?
Yes, I'm here.
Yeah, could you please introduce yourself while we're waiting for Dylan to set up?
Okay, I'm Darwin Chimba, fourth year medical student from Copperbelt University, Zambia.
Very good, welcome.
Nice to have you. Dr.
And
Meloni.
Thank you very much.
It's always great to have you here. Yeah, Dr. Meloni.
You're muted there.
Yeah.
I'll unmute you there, Marco.
So, John, you know, like as I was saying, I mean, it's always been great to listen to the presentations from Professor Ipe. I remember like a few days ago there was a conference, cerebrovascular conference, and a few neurosurgeons were actually explaining how to unlock the brain using the extradural clinidectomy, and all I could think about was when Professor Ipe was explaining this and the unfolding of the brain. It was pretty nice, and I'm happy that we have him here today, because I think we need to find ways that actually work for low and middle income countries, because that's what's striking right now. When you think about neurosurgery, you see all these things in the Western world and you ask yourself, well, is it going to work for us? Do we have to redefine things for ourselves? Do we have to change the way things are? Or do we accept the status quo? So I think this is good. Dylan, are you ready?
Yeah, not yet.
Okay.
I don't know why it's not reading my document.
What you can do maybe is you can send a PowerPoint to myself or to John. Then we can share the screen from our end, and then you can just comment the slides.
It's a good idea. If you're having too hard of a time, Dylan, yeah, just send us a link. Oh, I think you got it.
Great.
I think you got it.
Nice.
You're on the road, looks like. There you go. There you go. You got it.
Can you see my screen?
Yes, we can.
I'm trying to open the document. I don't know what's happening.
Okay.
It's taking a little bit of time.
There you go. Okay. If it's too hard, it could be because of the bandwidth. You might have to send us the file. Okay, there. Okay. You got it. Maybe you got it. Oh, it looks like it's opening slowly.
Yeah. Really slowly.
Yeah, just give a second. Give a second. I think, yeah, there you go. Okay, plan. There you go, Dylan. That's first page, correct?
Okay.
Okay, Dylan, can you hear me okay? Hello, Dylan.
So,
go ahead. Go ahead. I'm sorry.
Yeah, I can get you. Okay.
Okay.
Oh, okay. Okay, so in order to talk about the cerebral herniation syndromes, we're going to follow a plan in which we'll have a brief introduction. We talk about the patho
Oh boy. We're being challenged here by the tech.
And John, I can't see the slides.
You can't see the slide? We can see it okay here. Can you see it? Can everyone else see it okay? The
Yeah,
slide?
we can see the slides. I think Dylan is having trouble.
Now I can see. Now I can see.
Okay.
Okay.
Go ahead, Dylan.
It looks like he might. Oh, he's probably off. Yeah.
Yeah. I think we ultimately need to stop and have him send us the file.
Yeah.
One of us.
Let me try and get the file.
Yeah, well, I can edit all this out.
Yeah.
So, yeah, just text him, say to email you the file. It's probably not a huge file.
Yeah, it's just a network. The network isn't great, so
yeah. It's like neurosurgery, Marco. Sometimes things don't go according to plan.
Yeah, of course. Usual in our practice.
Yeah, you go, oh no, and then you got to think, how am I going to fix it? How am I going to move forward?
Absolutely. The best things to do is to overcome the problem and fix it.
Yeah.
Yeah.
One at
No
a time.
panic, no trouble, just go ahead, as we told.
Yeah, technology reminds me of the same as a neurosurgeon.
Yeah, it can be frustrating to be honest, because there's not much you can do, and you just the more you try, the more it's bugging. So you have to wait. You just have to sit and wait.
Well, you know, there's usually a problem with tech. I mean, and if you gotta try to stay cool and not go crazy, because
and learn from one way you experiment.
Did Dylan drop off? Did you hear from him? No?
Well, he dropped off. I texted him, but he hasn't read the message yet.
Okay. Okay, everyone. We'll edit. Adnan, how you doing?
Yeah, I'm fine. Just I was on call today and I'm doing duty in emergency.
You're at the hospital now?
Yeah, I'm in the hospital.
Oh, okay. So you could be called away at any second. Are you busy? Are you busy? It's nighttime there, right? It's is it busy there?
It's almost 9:16.
Oh, okay.
Thereafter,
are you at a busy hospital?
In the morning. Yeah, it's 2,200 bedded.
Oh my God!
Hospital with 80 bedded neurosurgery units.
Wow. So you busy usually on call?
Yeah, during the call, most of the time we are busy, but luckily at this time I am just relaxing in my room.
Yeah, you never know.
I have 2 other doctors. They are in the ward.
Okay.
John, I'd like to propose that since this is taking more time than it should, maybe Professor Ibe can go ahead and give us the different explanations that he has.
Yeah, it's a good idea.
While we have that, I'll be working with Dylan to have something.
It's a good idea. Yeah. Does he hear that, Ibe?
Yeah, sure. So I'm going to give you an overview of how the herniation syndromes progress. You know, they're not different. They're not different. They're all one spectrum. So I'm going to give you some clinical findings, some radiological findings, and how it progresses into something which is irreversible. Okay. So let's imagine you have the brain, and then you have the brain stem. Okay, so you have the brain like that, and you have the brain stem, and you have a tent which is around the brain stem. So the brain stem goes like that, and above the tent, all this side there is brain. All you neurosurgeons can imagine that, right? Yes, it's very easy to imagine.
Yes, yes. Thanks.
Right. So when there is a supratentorial mass effect, what starts happening is that the uncus is the most medial part of the temporal lobe. So that starts slowly going down. Okay. Because the uncus is almost at the brink of the tent. It is at the edge of the tent. So it's easy for the uncus to go down. So when the uncus starts, so the uncus is like that. You know, if the temporal lobe is like my hand, the uncus is turned like that towards the brainstem. This is my brainstem. So the uncus is turned. So when there is pressure, the uncus starts herniating first. So many cystonostomies I have seen herniated uncus. So the uncus starts herniating. First, it will herniate over the third nerve. So then what happens? The third nerve starts third nerve starts getting irritated. So there will be a brief time where when the ipsilateral pupil will constrict. And then as the uncus start herniating, what happens is the third nerve starts getting a paresis, surgical paresis. So therefore the pupil will, ipsilateral pupil will dilate. Now, what is the radiological feature at this time? Now, when the uncus herniates, what it does is it pushes the midbrain to one side. Okay, it pushes them because the uncus is just next to the midbrain. So it just pushes the midbrain to one side. So what happens? The pons also gets pushed. So the CP angle cistern, when the pons gets pushed away from the petrous bone, the CP angle cistern widens. You understand me?
Yes, yes.
Because the midbrain is getting pushed, the pons also, because brainstem is one structure. So when the uncus starts to herniate, the CP angle cistern widens, one pupil dilates. And the patient is GCS is still M5, motor score is still M5, one pupil dilating, and you see on the CT scan, the CP angle cistern is widening. Do you understand the significance of this? It is so important that it is this time that you have to catch the patient. You have to operate. Okay, one pupil dilating, CP angle cistern is widening, and you know, so the uncal herniation is starting. Now, if you wait, like the decompressive guys do, if you wait, what happens? The uncus will herniate, and then what will happen? The parahippocampal gyrus will also herniate. So what happens when the parahippocampal gyrus herniates? What happens is the CP angle cistern gets obliterated because the parahippocampal gyrus is also gone down. So the CP angle cistern gets obliterated. What happens to the brainstem? The brainstem, it gets compressed. It gets compressed. So you have a brainstem which is getting compressed. Because the brainstem is getting compressed, your GCS starts falling from 5 to 4 to 3. Your pupil is still dilated. One pupil is still dilated. And after that, what happens is the brainstem torsions. The brainstem, as the parahippocampal gyrus goes down, more and more parahippocampal gyrus goes down, the brainstem not only gets compressed, but it gets turned. And this is an irreversible process. When the brainstem starts torsioning, you get bilateral pupil starts getting dilated. You have ischemia because all the perforators, you know, the basilar artery is like that. Okay, so there are so many perforators into the pons. So when the brainstem starts getting compressed and turned, all these small perforators break, and you have multiple bleeds into the pons. What are these hemorrhages called? Anybody? What hemorrhages?
I don't know.
No idea, sorry.
No idea.
Huh?
Durate hemorrhage.
Duret's hemorrhages. Very good.
Yes.
Okay. Duret's hemorrhages. So they're called Duret's hemorrhages into the brainstem. So you see, now you see the spectrum, how it started. So first uncle herniation starts. Correspondingly, you will start having one pupil constricted, then one pupil dilated, and then CP angle cistern widens, and then parahippocampal gyrus goes down. So you have the CP angle cistern getting obliterated. Then after that, you have the brainstem getting compressed, brainstem getting torsioned. GCS falls from uncle herniation. The GCS was 5. When the brainstem parahippocampal gyrus goes down, GCS becomes 3 and 4. And once the parahippocampal gyrus is completely down, GCS goes to 2. And then both pupils dilate and it's irreversible. Okay. This is the classical spectrum of herniation. So I wanted to tell you this. And when you have CP angle cistern dilating in a patient where the CP angle cisterns were normal, this is a time you have to go for surgery. When you have one pupil dilating along with bradycardia or anything, you should not wait. If your intensivist tells you to wait, tell him, listen, you wait, I'll do my surgery. Okay. So these are times when you have to start doing you have to tell your intensivist, sorry, boss, we're taking this patient up for surgery. Okay. So, and you must know these classical herniation. This is a beautiful spectrum. And if you don't understand this spectrum, then you're going to sit down and wait. One pupil is dilating. You don't know what to do. You look for all the criteria and all that. No. So you should know the clinical symptom, the radiological features, and what is actually happening, the anatomy. If you link all the three, it's very easy to understand these herniation syndromes. Thank you very much.
Very good. We're lucky to have 2 other neurosurgeons here with us. Maybe you could comment on that, Dr. Cabullo. You know Dr. Cabullo. I think you met him in China, right? Oh, no, I'm sorry. You didn't go to China. Hey, Dr. Cabullo.
Hi, Dr. Bennett. How are you?
Good,
Hello,
good.
Professor. Hi. Hello, everyone.
Yeah, hi, Dr. Cabullo.
Hello.
Good to see
you. Could you make some comments, Dr. Cabullo, on the herniation and clinical signs, etc.?
Okay, I just joined. I don't know where you started. I think Professor said already everything. I can't comment after my professor.
Okay.
No.
Okay, okay, Marco, any comments or anything to say to IPE and to the panelists about herniation, clinical signs, and the need to go immediately to the OR?
Yeah, absolutely. The explanation of IPE was absolutely very clear, and anisocoria is the red alarm that's put the surgeon to operate in the briefly time as he can. In my department, usually we consider anisocoria red alarm. So the patients go in the operating room right now. When the patient is both dilated and has a cane stops breathing, usually we consider this situation, unless there is a young people, so you attempt something. But usually we consider this situation as unrecoverable. So usually we consider the patients lost when it's mydriatic and Cane-Stock syndrome. That's it.
Oh, okay,
Yeah.
very. Go ahead. Any comments, Hype?
No, nothing. It's correct. Yeah, I mean, whatever he said was right. Absolutely right.
Okay. You guys, I hope you realize how lucky you are. You're with 3 neurosurgeons talking about this. This is incredible.
Yeah, thanks, John.
Go ahead, Ulrich.
I sent you the Dylan's file in your email. So if you can share the screen so that he can present.
Oh, okay.
Thank you so much, Professor I, to have that clinical, radiological, and even operative correlation It's very interesting because, I mean, even more so because we don't usually have this invasive multimodality monitoring. So it's important that we all understand what the warning signs are and to be able to justify or not operative action.
Okay. So you're going to continue Dylan's presentation? Okay.
Dylan is going to continue. I sent you his folder in your email
okay.
box.
Oh,
if you can share that, then he can comment the slides.
Yeah, sure. Okay, let me check my email. Did it come from you personally? I don't have any.
The Hotmail address.
Oh, there we go. There we go. There we go. I got it. Okay, we should be cooking. Okay. Let me share the screen and you just give me the heads up on when to change.
Okay.
Okay. Do you see the presentation?
Yes, yes.
Okay.
Dylan, you can go ahead.
Oh, okay. Okay. So in order to talk about the cerebral herniation syndromes, we follow this plan, in which we have an introduction, pathophysiological basis of intracranial pressure. We'll talk about the forms of brain herniation and a little bit the management of brain herniation. Next slide, John, please. So as an introduction, the word herniation has Latin origin, to protrude. So it literally in its Latin origin means to protrude. In its Greek origin, it's like an offshoot. So basically, when they talk about herniation, it is an abnormal exit of a tissue or an organ through the walls of a cavity in which it normally resides. Next slide, John. So in herniation, we have key factors. We have compartmental pressure, so the pressure in the compartment in which the organ naturally resides. We have the tissue that is protruding and the walls or the opening through which it goes. So generally, herniation is linked to a space conflict with an increase in compartmental pressure in a closed cavity. The next slide, John. So applied to the brain herniation is therefore the displacement of brain tissue from one compartment to another through either the rigid dural folds, here we're talking about the falx cerebri, or the tentorium cerebelli, or the skull openings, precisely the foramen magnum. Next slide, John. So anatomically, talking about the anatomical basis, the cranium is a rigid, inextensible, closed box. In the infants and the neonates, where the sutures have not yet been completely closed, the cranium can accommodate a certain degree of increase in pressure, but in the adults, it's strictly a rigid and inextensible closed box. So this closed box is divided into compartments by two main dural folds, We talk about the falx cerebri, which separates the two cerebral hemispheres, and then the tentorium cerebelli, which separates the cranium into supratentorial space, which contains the cerebral hemispheres, and the infratentorial space, which contains the brainstem and the cerebellum. Next slide, John, please. So talking about the pathophysiological basis, we know from physiology that in the brain, we have various compartments. We have the brain volume or the parenchymal compartment. Here is about the brain tissue. We have the blood volume, be it the arterial blood or the venous blood, and then we have the CSF volume. And according to Monro-Kelly's doctrine, the sum of all of these volumes is equal to a constant, such that an increase or an additional volume, the presence of an additional volume causes the activation of regulatory mechanisms. These regulatory mechanisms imply the exclusion of the other volumes. As you can see on the tree-level diagram above, we see on the first diagram, we have the CSF volume in yellow, we have the arterial volume in red, and the venous volume in blue, and in the middle, we have the brain volume. So in the second diagram below, we have the addition of the fourth volume, which is a mass of any, it can be of any nature, in purple. And with that addition, we have the exclusion of the CSF volume to the right and the vascular or blood volume to the left. As the mass increases, we have the continuous exclusion of these volumes until the compensatory or regulatory mechanisms are overwhelmed and the intracranial pressure starts increasing. Next slide, John, please. So here we have a Lamfitz curve. On it, we see the phase at the level of the purple line. We see the phase, the compensatory phase, in which the presence of the mass is not associated with an increase in intracranial pressure because the compensatory mechanisms are there. But at the point of decompensation, when these compensatory mechanisms are overwhelmed, the intracranial pressure starts rising until herniation occurs at around 60 to 70 millimeters of mercury of intracranial pressure. Next slide, please, John. So when this herniation occurs, as we said, it is the passage of brain tissue through openings, be they openings of the skull or the spaces left at the level of the dural folds. So when this herniation occurs, we have consequences. They can be neurovascular consequences, so nerve compression, especially cranial nerve number 3 or cranial nerve number 6, the abducens nerve. We can have vascular consequences with arterial compression. Here we're talking about the branches of the carotid arteries, be they anterior, middle, or posterior cerebral arteries, anterior, middle, or posterior cerebral arteries, and with resultant cerebral infarction. You can have parenchymal consequences due to the compression of the brain tissue by the protruding, the compression of the general brain tissue by the protruding portion of the brain tissue. So we can have compression of the white matter, which will give motor or sensory deficits. We can have cranial nerve nuclei at the level of the brainstem that are compressed, and vital centers that are compressed too. For example, in cases of cerebellar or tonsillar herniation. We can also have cerebrospinal fluid obstruction that can be associated to a hydrocephalus, which increases the intracranial pressure. So, yes, next slide, John. So, talking about the herniation syndrome in proper, they can be caused by various types of lesions, either traumatic lesions, for example, in patients that sustain traumatic brain injury, tumoral lesions, vascular lesions, aneurysms, infectious lesions, or even congenital lesions. For example, Arnold-Chiari malformation that would be associated to a tonsillar lowering of the tonsils below the level of the foramen magnum. Next slide, please, John. So according to Plum and Posner, brain herniation can be classified from cranial to caudal into subfalcine herniation, transalar or transsphenoidal herniation, transtentorial or uncal herniation, central or central transtentorial herniation, cerebellar tonsillar herniation, and transcalvarial herniation or extracalvarial herniation. Next slide, John. Talking about the subfalcine herniation, in this herniation, it is first of all the most common herniation found at the level of the brain imagery for patients that in whom we have suspicions of herniation. It includes the ipsilateral, the displacement of the ipsilateral, the displacement of the ipsilateral cingulate gyrus through the anterior falx, and it is generally due to a unilateral or ipsilateral hemispheric lesion. Next slide, John. So radiologically or at the level of the CT scan, it can be identified with a midline shift. So a line that is drawn most often anterior-posteriorly in the position that should be occupied by the septum pellucidum. So if you have a shift of this midline towards a direction, especially at the level of the subfalcine area, we can suspect a subfalcine herniation. Besides that, we can have an asymmetry at the level of the anterior falx region with widened cerebrospinal fluid spaces on contralateral anterior falx, like we see on the diagram beside. We have, we can see the falx cerebri above the hyperdense line, and then we see that we have a displacement of the brain tissue just below this line with consequent compression of the ventricular spaces ipsilateral to the lesion, and we see a widening of cerebrospinal fluid space to the right in the opposite direction to the compression. Next slide, John. So the subfalcine herniation can be associated to some complications, notably a contralateral hydrocephalus due to the obstruction of foramen of Monro. As we said, it can be associated to a compression of these ventricular spaces, and an anterior cerebral artery territory infarction due to the compression of the anterior cerebral artery branches that pass through that region. Next slide, John. So next, we're talking about the transalar herniation or transsphenoidal herniation. So it is a not very frequent type of herniation. It concerns the herniation of the brain matter in and around the middle fossa across the greater sphenoidal wing. So it occurs usually in combination with subfalcine and transtentorial herniation, and can either be descending or ascending, respectively, in cases of frontal lobe mass effect or middle cranial fossa or temporal lobe mass effect. Other complications include mid-cerebral artery territory infarction or anterior cerebral artery territory infarction, or both of them, depending on the direction in which the displacement of the brain tissue occurs. Next slide, John. So talking about the transtentorial uncal herniation, which concerns the herniation of the uncus. Here we see it on the diagram besides with the G, the labeling G, which represents the uncal herniation. So it concerns a displacement of the hippocampal gyrus through the lateral border of the tentoral incisura. It results in a compression of the ipsilateral cerebral peduncle, knowing that part of the pyramidal tract goes through that cerebral peduncle, a compression of the posterior cerebral artery, which is possible, but not very frequent, and a compression of cranial nerve number 3. So among the clinical manifestation, we have an ipsilateral dilated pupil. You can have a hemiparesis that will either be ipsilateral or contralateral, depending on whether it is the ipsilateral cerebral peduncle that is compressed, in which case the hemiparesis will be contralateral, or it is the contralateral part of the brain tissue that is compressed against the lateral border of the incisura, and in which case we give an ipsilateral hemiparesis, also known as Kernohan phenomenon. Next slide, John. So here we see a patient having sustained traumatic brain injury to the left, and we see the anisocoria that the patient presents. On the one side, to the right, we have a tight pupil, and to the left, we have a relatively normally sized or a little bit dilated pupil. So, and on the right image, we have a completely dilated, widely dilated pupil, which in this case will be indicative, especially if associated to a hemiparesis, will be indicative of an uncal herniation. Next slide, John.
Hold on, I'm having a little hard time here. I'm having my own technical difficulties.
Okay.
Hold on. Hold on. Okay, there we go. Hold on. I'm sorry about this. Okay. Tell me which slide. Next one.
No. Go back, I think 2 slides behind. Again, another slide. Okay, next slide.
Back or forward?
Forward. Okay, so after the transtentorial uncal herniation, we have the transtentorial central herniation. Here it's about the displacement of the diencephalon through the tentorial incisura, and it's most often related to bilateral hemispheric expanding lesions that cause equal compression on both sides and displacement of the diencephalon through the tentorial incisura medially. So clinical manifestations can include altered consciousness, tight pupil, abnormal respiratory rate with a chain stalk respiration. Next slide, John. Talking about the tonsillar herniation or the cerebellar herniation, in this case, it's mostly a cerebellar herniation. It concerns the descent of the cerebellar tonsils below the level of the foramen magnum. So it's sometimes termed coning. When it occurs, it is termed coning. And as we know, the brain stem, which is just passing through the foramen magnum, contains the major life-supporting centers, be they the respiratory or the cardiovascular centers. So as this occurs, we have a subsequent compression of the brain stem against the borders of the foramen magnum. And the consequences, as we see, the compression of the brainstem against the clivus on the one side, with a consequent compression of the life-supporting centers, and you can have either respiratory arrest, or we have compression of the vertebral arteries. As we know, the vertebral arteries pass at the level of the foramen magnum too. So compression of these vertebral arteries leads to massive bilateral cerebral infarction that can lead to immediate death in the patient. So this one particularly is an emergency. Next slide, John. So at level of the CT scan, we see here to the right, we see a brain with an MRI. We see a brain that has really important cerebral edema, and that edema is really very pronounced at the level of the posterior cerebral fossa. So we have an effacement of cerebrospinal fluid systems surrounding the brain stem, which is a sign of tonsillar herniation. And besides, we can have an inferior descent of the cerebellar tonsils below the level of the foramen magnum, which we see clearly at the level of the image, the MRI to the right. We see the descent, and even the brain stem that goes a little bit lower, and we have its compression at the level of the foramen magnum. Next slide, John. We also have extracalvarial herniation. In this case, it is the herniation of the brain tissue external to the calvaria through a bone defect at the level of the skull. Either it is post-traumatic bone defect or a post-surgical bone defect. So in this case, it is different from encephalocele in that it is not surrounded by meninges. So it is not a malformation. It is an acquired lesion, either following a surgical procedure, for example, a decompressive craniotomy, or following a head trauma. Next slide, John. So concerning the management of cerebral herniation, the management has to be engaged upon recognition of the clinical condition. So immediately upon recognition of the engagement, especially if it's an acute herniation, upon recognition of the herniation, management has to be instituted. And the immediate goals in a way for etiologic treatment, the immediate goals include the reduction of the intracranial pressure while maintaining cerebral perfusion pressure and oxygenation, which is very important as we know that the brain is a matter of blood perfusion and oxygenation. Second, prevention of secondary injury, amongst which you have hypercarbia and acidosis. The means for the management of for the obtention of these immediate goals include the blood pressure management for cerebral perfusion pressure, controlled ventilation for oxygenation, and intravenous infusion of mannitol for reduction of intracranial pressure. All these measures are immediate measures, especially in the acute herniation syndromes, and are used to allow the brain to accommodate the underlying lesion in a wait for etiologic, for definitive diagnosis and etiologic treatment. In this case, we're talking about if it is, for example, a brain trauma, in a wait for a surgical procedure, either burr holes or craniectomy, depending on the cause of the brain herniation. Next slide, John. So the methods for the obtention of these immediate goals, as we said, we have reduction of intracranial pressure, maintenance of cerebral perfusion pressure, and oxygenation. So first, initial resuscitation. Here, it's mainly applied to acute cerebral herniation syndromes. So first, we have to ensure airway and add a proper airway. It has to be ensured, especially if need be, intubation should be considered with 100% oxygenation. Hyperventilation can be used to, with partial pressure in carbon dioxide brought to the level of 30 to 35 millimeters of mercury, and it is accepted by the Brain Trauma Foundation and the American Association of Neurological Surgeons in cases of expanding hematomas causing transtentorial herniation. So we have to note that it is a dangerous procedure to some extent because it can be associated to cerebral ischemia, so it should be used with some degree of precaution. Circulation and blood pressure monitoring in order to maintain cerebral perfusion pressure. Then besides the initial resuscitation, we have intravenous infusion of mannitol, which unless in cases of hemorrhagic shock, the recommended dosage for intravenous infusion of mannitol is a bolus of 1 to 1.5 gram per kilogram of body weight of mannitol. And then besides this measure, we have the subsequent etiologic treatment in order to remove the underlying lesion that causes the herniation. So concerning the prognosis of these patients, we have overall the prognosis is poor but not hopeless. For example, functional recovery can be quite good, especially when we have young patients who exhibited reversal of the clinical herniation signs when they received mannitol and hyperventilation, and who have a removable intracranial, who have a removable intracranial lesion. Besides that, we have the mortality is quite high in cases of transtentorial lesions, transtentorial herniations, and also following traumatic herniation, following traumatic brain injury or traumatic herniation, age is a profoundly negatively impacting factor. So the older the patient, the more the prognosis is really poor. And then in cases of non-traumatic cerebral herniation, we can have a good functional recovery for those patients, especially if they are young patients. Next slide, John. So here we have a visual abstract that was published a few months ago that discusses the efficiency of the common physical examination signs that we have for the detection of raised intracranial pressure, and compares them to invasive intracranial pressure monitoring measures. And overall, it tends to show that we have a really very poor accuracy in detection of elevated intracranial pressure as when these measures are used. So they recommend that in case of high suspicion of raised intracranial pressure, the patient be transferred to an intracranial pressure to a center which can afford intracranial pressure monitor placement. So it was like a question, knowing that we have all of these strategies for low and middle income countries that we use, especially clinical measures for detection of raised intracranial pressure. So it really brings up the question of what then, in terms of low and middle income countries, for the detection of this raised intracranial pressure and subsequently prevention of cerebral herniation. Next slide, John. Okay, thank you for your kind attention. Yeah.
Oh, excellent, excellent, Dylan. Thank you for facing the technological problems and getting through a great presentation. So we'll open it up to any comments for the panelists, especially the neurosurgeons. Any comments or questions, Ulrich?
Yeah, thanks, John. I wouldn't go straight into the, well, first of all, good job, Dylan. I mean, it was a really great presentation. We had a few elements that Professor Aibsheran mentioned earlier, and it's actually wonderful given that you weren't here when he was explaining that. So thank you very much for this great job.
Thanks, Ulrich.
Okay, Dr. Kabulo or Ipe, any comments or questions?
Yes. Thank you so much, Dr. John. Thank you, Dylan. Great presentation. I wanted just to, the first one is a question, then I have a few comments. What did you say about the dose of mannitol?
Pardon, Dr. Kabulo.
Yes.
I didn't get your question, please.
Okay, what's the dose of mannitol?
Mannitol, the recommended dose was 1 to 1.5 gram per kilogram of body weight.
Yeah, I don't know. Usually they say it's 0.25 to 1 gram per kg. I don't know if Professor Ipe will give us more light. It's 0.25 to 1 gram per kg. Then,
yeah, I saw the. Yes. So, yes, I mean, I saw that in the document I used. Actually, they said they described the mannitol dosage, and they said it changed over time. So initially it was 0.25 to 1 gram per kilogram, she said, but that recently the recommended dosage was 1 to 1.5 gram per kilogram. So I don't know, so that I'm not really an expert in that domain, but that's what I saw.
Okay, before I go to the second comment, if Professor Ipe can tell us something.
Well, in my unit, we don't use mannitol at all, except for just buying time. So if we have to buy time, for example, we have some delay shifting a patient to theater for an extradural or a subdural or something, that's the only time we give mannitol. Otherwise, in my unit, we never use mannitol. So it has a lot of disadvantages. You must understand that mannitol produces a lot of electrolyte disturbances, most notably hyponatremia. So if, you know, over the last 10 years, what we have adapted is we have gone from being reactive in head injuries to being proactive, which means we look for all the signs and symptoms. And as I've always told, in the West, they can afford to have multimodal monitoring and everything. European countries and United States, they can afford all this, but you must understand 5/6 of the trauma is happening in the rest of the world. So these places, you cannot afford to have a patient on multimodal monitoring, and you do not have the manpower to look at a patient and keep on monitoring all this. It's impossible. So we're looking at two different scenarios. So you need to be in developing countries, we need to be very proactive. It's extremely important that we need to be proactive. So when you have trauma, when you have herniation syndromes, as I have mentioned to you before, if you have a dilated pupil, unilaterally constricted pupil, even along with bradycardia, you have dilatation of unilateral pupil, or if you have a CPI angle cistern widening, or if you have drop in motor score, these are scenarios where in the West, maybe they can afford to wait, but not 5/6 of the rest of the world. We have to act, and action is not by doing something like a decompressive, which is a 100-year-old surgery. Action is by learning how to get into the base of the brain, understanding what is CSF shift edema, unlocking the brain, letting out the CSF, getting a lax brain, learning how to do that. This is how the head injury scenario has to change. So this is what my comment would be for my colleagues in Africa.
It's fortuitous that you're here today, talking about this subject. And I have a question. It's from a non-neurosurgeon. You see this fairly frequently, or is it once a week or once a month? Is it a very brain herniation? Do you see it a lot?
Oh yeah, I mean, in any center, in any busy center, at least 2 or 3 per day, John.
Really? Okay, so it's a common thing. Yeah.
In every busy center, I'm talking about. I'm just not talking about my center. It's every big center, 2 or 3 cases per day. In India, you take India, China today. The Indian skull-based conference was going on. Dr. Parthiban was talking about cystonostomy. So, you know, in every center, every state, this is the maximum burden. And you must understand, and I'm sure it's the same in Africa. It is the same in Latin America. It is the same in India, China, most places like Malaysia, Indonesia, everywhere. So the problem is that the guidelines come from Europe and US. So, and their situation is very, very different from the situation seen in these countries where 5/6 of the world's population resides. So they really don't know about, except for a few guys like Randall who's traveled outside, they really don't know about the scenario of head injuries in these countries, in low and middle income countries. And there, you know, one of the things is very interesting things is that most of these places don't have microscopes for trauma. They might have a microscope for elective cases, but they don't have a microscope for trauma, which is really sad. This is why we are trying to develop a new microscope, which is much, much more cheaper and very good. We're trying to do it with a company where this microscope will cost maybe less than 1/10 of the price of a normal microscope. So we are in a phase where in about a year we'll have a good prototype, and then we can you know, what inspired me to do this was that many of my fellows who went to South America and to Africa, they said, well, cystonostomy is not practical because we don't have a microscope. So so we are trying to develop this microscope so that we can you know, inspire the rest of the world also to take up microneurosurgery.
It's obviously an ominous clinical state. When someone reaches that point, do they usually end up with either dying or having like almost a vegetative state? And what percentage don't recover, and what percentage do recover?
Yes, so the most important part here is the motor score, John. So the motor score 5 is a very, very good score. So if the motor score is 5, the CP angle cistern is widening, unilateral pupils are dilated, this is the time to take up the patient. But if the motor score is 3 and 4, and unilateral pupil is dilated, then the chances of recovery is good. Chances of recovery is good, but the functional recovery is not as good as in motor score 5. There's a huge difference between, this is what in last 10 years, over 1,500 patients, what we think the most important thing is motor score 5 versus motor score 4 and 3. There's a huge difference. Okay. The 4 and 3 patients, they stay on in the hospital for a longer time than the 5 patients. Some of them may be on tracheostomy, but they generally do okay. But once it comes to motor score 2 and 1, pupil is dilated, then we're looking at mostly vegetative states. Okay. Some of them, the miracles do happen, but most of them don't either don't make it, or even if they make it, it's vegetative.
Vegetative state.
Yeah.
Okay. Okay, very good.
I think Dr. Meloni wanted to add something there.
Okay, Marco, go ahead.
Yeah, I just want to share my experience. In my department, we have, of course, is a emergency department, so we have a lot of trauma, but we have also a lot of typical hemorrhage of the thalamic hemorrhage, causing patients in anticoagulant therapy and hypertension. In this case, we apply, above all, when this hemorrhage go into the ventricular system, we put an external vertical drainage that allows us to not only avoid hydrocephalus, but also to check the intracranial pressure. So has a good monitoring of patient internal intensive care. And usually these patients recover very well, of course, with hemiparesis, but they have a good recovery, avoiding the hydrocephalus. So I don't wait. The patient is dilated and in Glasgow Coma Scale 4, but I put right now the external ventricular drainage to allow the intensive care monitoring, leaking of liquor, so avoid the intracranial hypertension caused by hemorrhagic hydrocephalus. That's my experience. And another thing I absolutely agree with what was telling Hype. We need to reconsider the surgery in this case, because we're losing the legacy of Yazargil, as is a microneurosurgery. We have all the potential to perform microneurosurgery by cisternal approach, and we're losing, preferring more conservative therapy. We have also all the opportunity to do surgery in a gentle way and with better results. So I think that we need to reconsider what we have in our own hand since many years. That is the Yazargil and the whole people like Hype to of microneurosurgery.
John.
Go ahead.
John.
Yes, go ahead.
So we have another person from Cameroon, Prochizia. She's a biomedical engineering student, so she probably wants to come back. She's studying in India. She would probably go back to Africa, and maybe she will be heading some manufacturing these kind of microscopes and CT scans.
Oh, excellent.
And so
excellent.
I don't know whether she's on. I think I saw her join up, but she's very interested, and she will be coming to our center to visit us from Cameroon. So I don't know if she's into this.
Yes, she's here. John, do you want to unmute her? I see the name.
Sure.
Patricia.
Where's she at? Patricia?
Yeah.
Prochizia?
Yeah.
Okay.
Yeah. Prochizia, can you put on your video, and are you there?
I'm trying to unmute her. She's not unmuting. Prochizia, can you hear me? For some reason, we're having difficulty opening her mute. Patricia, if you unmute yourself if you can. I'm having a hard time unmuting you. While we're waiting, you mentioned another system of scoring. It wasn't the Glasgow, the modicum or something. What did you mention?
Motor score in Glasgow comma score. The most important, you have EMV. So you have I and verbal, but then the most reliable part of this score is motor, because in verbal you could have an aphasia, or you could have any other problems causing speech disturbances. And I is not very reliable. So the most reliable part of this score is motor. So that is why we have to, we go by motor score. So motor score 5 is when the patient can be brought back to almost normal, while motor score 4 and 3 is when already the parahippocampal gyrus is herniated usually, and the recovery is not very good, while motor score 2 and 1 is very, very bad.
Okay. Well, Patricia, I'm glad to say is here. Hello, Patricia. Could you please introduce yourself?
Hello, I'm Patricia.
Yes. Could you tell us
I'm
what you do?
I'm studying in Palu University, taking biomedical engineering.
Okay, and you're going to Nepal to work with IPE? Very good. When are you going?
On 26th of this month, the end of the month.
Okay, and you're going to work with IPE to try to develop a lower priced microscope?
Yes.
What does that take? You must know technology and medical devices, etc. I guess we're having bandwidth difficulties there. What does it take, IPE, to get a low price microscope? There's certain parts, the lenses, is that the thing that's really expensive? What's the things that are very expensive about a microscope?
Yeah, so John, the thing is, the microscopes of today, for example, today's microscopes are costing, the best microscopes are costing $1 million.
Right.
On the other hand, a webcam, for example, a normal digital cam, 4K camera, if you can attach it to a single arm and use 3D, just a 3D cam with 4K, it doesn't cost you more than $15,000 to $20,000. So if you can have a 3D cam attached to an arm, and you can watch a screen just like you do endoscopic surgery, you can do most of the thing what a microscope can do. And it is much more easy as well. So I am actually working with Karl Stoves. I've been, for the last WFNS meeting in Beijing, I took their exoscope on their arm, and I demonstrated Dolling's to the Dolling's approach, as well as anterior petrosal approach to in the WFNS seminar in Beijing. We did even microvascular anastomosis with the exoscope. So, but the exoscope is also very costly. So we're trying to make a very, very basic digital 4K cam, which is 3D, attach it to a good arm, and even go up to and even upgrade this so that the arm could be robotic, and we can get navigation into that. So many things we're doing. So and it will not cost anywhere near the present microscopes. And also we're trying to make cheap, very, very cheap drills, debriders, CUSA. CUSA is actually really cheap. If you know how to make a CUSA, it's really, really cheap. But the CUSA companies, they hike up the price so much that no countries, LMIC, the low and middle income countries, no neurosurgeon can afford these kind of things.
Right.
So we are trying to make something affordable for the rest of the world. So very soon, in a couple of years, you can expect us to come out with this.
I know you recommend a microscope for cysternoscopy. Is it possible to do a decent job without the microscope, or it's impossible to do a good cysternostomy without a microscope? It's very difficult. Wouldn't even try it. Wouldn't even try it. Okay. Okay.
Yeah, I wouldn't be recommending it without the microscope because it's extremely risky to do that.
Okay.
Hey, John, you should know that Professor Ibe really likes the microscope. He operates on that really high magnification. So so you have to be really delicate. You can't go there without a microscope. You probably come out with a lot of a mess. You'll be a mess. Yeah.
Right.
So you need a microscope.
Okay.
I like very, very high magnifications. For example, if I'm doing my aneurysms, I have 42 magnifications. So I use I have ProMag, I have the 3-step magnification changer, and also I have my Pentaros usual magnification. So I put all that into maximum. Sometimes light is a problem. When we have that high magnification, stereo depth and light is a problem. But even then, I like that kind of magnification to work.
I put the learning curve for a neurosurgeon and resident to learn how to use a microscope that hasn't been exposed to it before. What time frame are you talking about?
See, I am trying to abolish the microscope per se, but if you want to talk about operating at a higher magnitude, yes, there is a huge learning curve involved, and the more you work with the microscope, the more you work with magnification, the better you will be. I mean, it's very, very to start with, it is really terrible to work with high magnification. It's you will be disoriented. Your big vision will, I mean, your vision about the whole anatomy would be distorted, and you know, instead of seeing this entire hand, you are seeing only one line, like that. Okay, so you don't know where the hand is, and you are working. You really don't know. Only this part of the line you are seeing, like this. This is what you are seeing, and with this hand, with this line, you should know where the hand is, and you should exactly know where each thing is. So most of the problem is when you work at very high magnification is that you are disoriented. And this can lead to disasters sometimes. So it is very important for you to zoom out sometimes and then zoom in back. And when you are lost, or when you have any doubt, you need to zoom out completely and see everything, and then zoom back again. Even now I have this problem. So I can imagine, I have been doing this for almost 15 years. So even now, sometimes I get disoriented. So especially during petrosectomies and other long drilling or mastoidectomies or things like that, I get disoriented. Of course, everybody gets disoriented because the position of the patient is sometimes different. So it is a learning process. It keeps on going on for a long time. And when you're working at such high magnification, it's very, very important.
So it's recommended that obviously you work with someone else to tutor you in learning it. How soon would it take a person to become good, able to do it alone? Would it take months, a couple of weeks before you can do it on your own? How long would it take to do with a reasonable facility, a reasonable being able to do a case on your own? 6 months?
So this is what we are starting a program called Neurosurgery Coach. So from January 2020, we're starting a program. It's a 1-month program where, well, there is a lot of things we are teaching. We're starting with chopsticks. We're starting with micro scissors, how to hold micro scissors, how to hold a suction, how to hold a drill. And one of the things would be a 2-day session on the microscope, how you can use the microscope to the maximum. This is what, so the angles of the microscope, they are very, very important. So how you adjust the angles of the microscope, how do you sit with the microscope? What are the things that you can do with the microscope to make your life better when you're operating? All these things we're going to be teaching there.
Yeah.
So the thing is, we don't have professional neurosurgeons, you know, professional players, all professional players have coaches. Okay. So if you see, any football player or any tennis player or any badminton player, they have coaches. So they make them professional. So they have a clear mindset, situation awareness, management of complications, if there is failure, what to do, and how to be the best with skills. So this is what we are planning to teach in this neurosurgery coach. So I hope we mentor people and we can tell them how to. And within this 1 month, I hope they can reasonably start using the microscope properly.
Yeah, we're gonna talk.
That's a great idea, Professor. I think that's one of the advices from Atul Gawande. He actually wrote a paper about that, about having coaches in surgery, and I think it's even more important for the young neurosurgeon that goes back to a low and middle income country, because you have to settle by yourself and you don't have any bearings, so you have to find out how to manage all these things. And it can be difficult because when you see a difficulty and then you're just on your own, you have to bear the responsibility. It's not that easy. And John, on your question about like the learning curve is obviously steep. You have to spend a lot of time in the lab. You have to be in the microanatomy lab. Every one of the greats will tell you this, and I think Professor Ibe has said it so many times. The microscope has to be an extension of your body. Your micro instruments have to be an extension of your body, and that doesn't just happen. You're not born with microanatomy in your head, so you have to spend that time. The difficulty for us, obviously, is we don't have the labs. But there was an article recently about being able to build a sort of a microscope from your smartphone plugged in. A very good article, actually, and you use that. You plugged it into to power it, and you can use that to have the feel. It's not the same as having a microscope, obviously, but the more you practice, the more you get there. So
very good. And Ipe is going to talk about the neurosurgery coach program tomorrow, right, Ipe?
I can talk about it, but I didn't know that I was going to talk about it.
Oh no, I thought that was your topic tomorrow. Were you going to do a Super Sunday tomorrow?
Oh yes, tomorrow is Sunday. I forgot it completely. Yes. Yes. I have a couple of surgeries. Definitely, I should be finishing before 5, and then of course I will talk about tomorrow. We have a MCA aneurysm, MCA bifurcation, very complex MCA bifurcation. So I'll finish that, and then I'll maybe I can show you some interesting videos. And then right now we have a fellow. We have Andrea Girosa from Italy coming day after tomorrow, and then we have another fellow, another neurosurgeon from India who is right now at my home. So he is also here. So tomorrow we will get all of them to participate, and then we can do this.
Okay, tentatively tomorrow at 5 o'clock. Tentatively. Yes, okay, all the panelists, I hope you come tomorrow at 5 o'clock India time for Ipe's discussion of the neurosurgery coach. We'd like to hear about it. So any more questions or comments from the panelists?
Yes, I have a comment.
Go ahead, Dr. Gabulo.
Yes, it's to Dylan. Dylan, I wanted just to share with you an algorithm we are using in Africa. Since you are also in Africa with us, sometimes you want to have a CT scan machine which is functioning, or sometimes we are at the center where no CT scan machine. So usually you get a patient like what you were explaining about on transtentorial, the ankle herniation. You get ankle herniation with the CT scan machine is not functioning. So how will you do? How will you proceed? Like if you are deciding, because we are still doing exploratory BEOs, we are still doing exploratory craniectomy, exploratory craniotomy in Africa. I'm talking about Africa. So that's what you mentioned clinically. For ankle herniation, you get hemiparesis, you get pupil dilatation. Usually the pupil dilatation, that's the most important sign, which is going to tell you where the lesion is. The moment you want to discuss, to decide which side will you go if you don't have a CT scan machine. The result, most of the time our CT scan machine are down, they are not functioning. So you go the side where the pupil is dilated. You don't follow the hemiparesis because that one can mislead you, like in Kenohan phenomenon, like what you mentioned before. if you follow the hemiparesis, will mislead you. You go the side where the pupil is dilated, that's where the hematoma is, if there is extra axial collection. Then in case both pupils are dilated, then you have to ask if there's someone who saw the patient before you, which pupil started to dilate, then that's the side where the lesion is. If there's no one who saw the patient before you, you just saw the patient with bilateral pupil dilatation, then you check the side where there is external injury on the head. The side where there's external injury, usually that's where the lesion is. Then if the patient doesn't have an external injury, then you start decompressing the dominant hemisphere. You start with the dominant, and usually if you are doing a BEO or if you want to convert it to craniotomy later, you start with the temporal one, then frontal, parietal, occipital. Then later on, you can still continue and do a craniotomy. So that's how we proceed in case you don't have a CT scan, but you decide to do an exploratory. So in summary, the side where the pupil is dilated, that's where the lesion is. If both pupils are dilated, you check which one started to dilate. If no one examined the patient, you don't know which one started to dilate. You go the side where there is an external injury. If there's no external injury, then you start with the dominant hemisphere. Just a small algorithm we use in Africa. Thank you.
Okay, thanks so much, Dr. Kabulo.
Very good. Any more comments or questions from the panel before we wrap it up? Okay, thanks everybody for coming. Thanks, Ipe, for coming out. And we're going to see you tomorrow around 5 o'clock for neurosurgery coach. And thank you, especially Dr. Kabulo and Marco. Like I said, you students are so lucky to be in the same room with 3 neurosurgeons as a medical student. That never happened to me during medical school. Anyways, thanks very much, and we'll wrap it up. Thank you.
Yeah, see you guys.
Okay, very good, Ipe. Okay, we're off the air. That was good. See, Ipe, these kids don't realize it, man. In medical school, rarely will we have a one-on-one conversation with a neurosurgeon. It was rare.
The first time I had, we in our faculty, we had the opportunity to speak with a neurosurgeon was in the 4th year, I think so, the 4th year. Fourth year. So, and then even we only had, we spoke with him for something like 2 hours. On the GPS, yes, for 2 hours, and then we never saw him again.
Yeah, maybe a few minutes. That's about it.
Yes. So we never saw him again, and so it's a blessing. It's a blessing to be able to have 3 of them, 4 in the same room. That is wonderful. Thank you very much for everything.
Yeah, it's a great technology. I should have had, Ulrich, I screwed up as a producer. I should have had a copy of that PowerPoint in case of problem. We'll have to do that in the following weeks, Ulrich, okay? Let's make it a regular thing that I have.
He left already. He left.
He left. Okay, very good. Very good. Okay.
All right.
We have a couple more panelists here. Raphael, Kaya, how you doing?
I'm fine, sir. I'm fine. Yeah, I don't want to pass unnoticed.
Yeah, please. Yeah, please introduce yourself. Part of the value of this is meeting people like Ipe, Marco, and Dr. Kabulo.
Exactly.
John, somebody wanted Zolo, or somebody wanted my email or something. I'm sending it to.
Okay, you want to put it in the chat box or just email? You send it to me, I'll put it in the chat box.
All right.
I'm typing. I have sent it to Dr. I've sent it to Zolo.
Okay. Okay, Raphael. Raphael, where are you at? Are you in Cameroon?
Yep, exactly. I'm a classmate of Zolo, so we are always together.
Oh, okay. Yeah, Zolo's done some awesome presentations. Hour-long presentations. Good ones.
I've seen it.
You seen it?
Yes, I've seen it. It was so challenging. I was asking myself, am I in the same class with this guy? So I know it was so amazing.
Yeah, it is for a medical student to make an hour-long presentation. It is incredible.
Exactly. Actually, it's an honor to be here with you and all these doctors, professors of neurosurgery. So I think, as Zolo was saying, we had our first encounter with a neurosurgeon in 40 years when we were teaching just basic neuro anatomy skills. So after then, no one. So even in the theater, when we met just once, so it's a little bit rare in our setting. So it's a great pleasure and honor to be among you professors.
Very good. You and all your fellow students are always welcome to any of the, not only the African neurosurgeon webcast, but any webcast we have in neurosurgery. You're welcome to come, and you don't have to talk. You can just watch.
Exactly.
Don't feel you have to, come up with some remarkable statement. No, just say, hi, I'm John. I'm from Miami. Nice to meet you. That's all. So any of your students are welcome.
Thank you. Thank you so much.
Okay, Dr. Kabula, how you been?
I'm glad to see my senior, Dr. Marco. It's been a while. I saw him.
Yeah, he's back from the Greek islands.
Yeah, welcome back.
Thank you, guys. Thank you.
Oh, actually, you were in Crete, right? Crete, you said. You went to Crete, right? Crete?
Yeah, great. Exactly. Just 1 week for holiday. It was a half and half period, September. Half in Rotterdam with a hands-on skull-based course with Dr. Krish from Arkansas. The other half holiday in Crete.
Oh, okay. Okay, yeah, 2-week vacation, right? 2 weeks a year.
Yeah, but it was beautiful, absolutely beautiful. I repeat again more and more.
Yeah, someday I'd like to. I love going to Santorini, one of the Greek islands. It's not too far from Crete, matter of fact.
No, not at all. There is a boat that can carry on to Santorini.
Yeah, the ferry. People we took a plane back, but getting there we took a ferry. It goes from Athens all those islands. It goes.
That's right.
You can get around pretty easily with a ferry boat.
Yeah, absolutely. There are great connection between islands in Greece. It is absolutely amazing. There's a great sea, very blue sea.
Yeah, I've never seen anything like the Greek islands before. I never have. It's truly unique. And the white, I didn't realize it, but they have a strict code. You have to make the buildings white. It has to be white.
Yeah, correct.
Thank you so much.
Correct.
I will see you tomorrow. Bye-bye.
Okay. Thank you, Dr. Bullo. Thank you.
Thank you, Kabulo.
Thank you. Bye-bye.
Yeah, there's some kind of law. Your building has to be white in the Greek islands.
Correct. Is the main color is the white
and the blue.
And blue with the roof blue and the building white.
Yeah, it makes your island look really wonderful. I think it was a good idea to do that.
Yeah, it's a little Mediterranean background. Correct.
Well, yeah, I can't wait to go back. It's just a wonderful place. Okay, Zolo.
Yes, doctor.
Yeah, don't feel bad about your computer. We should have prepared next time. We'll send your PowerPoint to us before.
No problem. I'm okay. I'm all right. It was wonderful having Dr. Marco around, Professor Ive, and all the rest. So it was really great. So I enjoyed myself.
Good. It went well. It went well. Because the PowerPoint slides look great, even in a low bandwidth. Even if you have a poor connection, those slides look great. Just as
actually
good as anywhere else, any other high bandwidth place.
Yes.
So okay.
All right.
Thank you very much, Marco, for coming.
Okay. Thank you very much, everybody.
Zolo, thank you. We'll see you. Bye-bye.
Okay. Tomorrow.
Yeah, tomorrow. If you're around, Marco, I'm going to talk about if you have time. Okay, you'll get a link. Okay.
Okay. Thank you.
Okay, see you. See you, Zolo. Bye-bye.